Right. Good evening, everyone, for my friends in the US and Europe, and good morning for those in Asia Pacific. Thank you for joining us for what promises to be a very intriguing and interesting debate. Hopefully no actual punches will be thrown as it's a virtual meeting. I think we've got a great group of experienced surgeons here talking about different techniques. And what we're talking about here is indirect decompression infusion. So we're not abandoning laminectomy, discectomy, endoscopic decompression for all the routine indications. What we're talking about here is if you choose to fuse someone, then do you have to actually decompress extensively at the same time or not? Talk about some of the parameters around that, show some cases, but it is a hot topic and a lot of people have their own very sort of personal opinions on this. So it'd be good to get some of that out in the open. Session will be interactive. We'll get into questions from the audience as well. So joining me is Gergely and Samir from Germany. They'll go first. It's a really late night there, and I thank them for staying up and working with us on this. We'll also they'll be talking really about indirect decompression, their parameters around that. For Team Direct Decompression, we've got the All-Star Brown University team of Alan and Basil, and they'll talk about that. And then further rebuttals will come from Peter Derman and David Yam. So it's going to be interactive, it's going to be interesting, and we're just going to get into it. Please put questions in the chat box, and we'll be moderating and answering as we go. And feel free to hit us up with any questions later on LinkedIn. Thank you very much for joining us, and we'll get into Gergely's talk now. Thank you.
So, hope you can hear me. I have just some trouble seeing you. You can hear me. Okay, I will just go on like that. So, this is about indirect decompression, and this is kind of an interesting topic. We have still quite many open questions, basically. But upfront, I would like to say two things. First is this is for patients who need a fusion. And the second is this is not an alternative to direct microsurgical, endoscopic, or tubular decompression. And they also have, of course, different indications. And yes, we can, and yes, we do decompress directly if it's needed. These would be our objectives for today. And I will show one case at the end. But first, we have to understand what happens really in degenerative disc disease. Basically, if you are looking at the degenerative cascade, it all starts with dehydration and disc height loss up there, leading to increased mobility, bulging of flavum disc, posterior longitudinal ligaments, leading to symptomatic spinal canal stenosis, later on discogenic pain, asymmetric degeneration, degenerative listhesis, and bone spur formation, facet joint hypertrophy, and at the end, ankylosis. So this is basically a fusion in the wrong position and with some neural compression. If you look at the picture, there are like a couple of red words there. This is disc height loss, and we have to accept it that most of the pathologies we are treating on a greater number, disc height loss is a main factor in sagittal imbalance, fractional curve, coronal imbalance by asymmetric degeneration and asymmetric disc collapse. And also by spondylolisthesis, because if you're looking at the lytic spondylolisthesis, they are usually coming to you when they are after 60, and they have a disc height loss and degenerative disc disease and foraminal stenosis. And if it is a degenerative spondylolisthesis, they are coming to you because of the disc height loss and the central canal stenosis. So disc height loss plays an important role, and it has to be treated. And this is one of the main goals of fusion surgery, disc height restoration. Now, what some interesting thing happened as we started doing surgeries in patients with anterior support and indirect decompression. And after doing a second stage surgery, some of the patients say they don't want to get operated for a second time because they got rid of their claudication, and also they got rid of their radicular pain. And we had to understand that first, because it was not clear for us. What we found by the first MRIs, this is one of the first MRIs from a couple of years ago. You see preoperative pictures on the left side, postoperative pictures on the right side. Basically, what is gone is the disc bulge. So what you get is that the anterior compressive factor, because of the disc bulge, is getting smaller, and it's not a big number. It's usually getting smaller with 2 to 3 millimeter. This is what you get, and this 2 to 3 millimeter increase means an increase in the sagittal diameter of the spinal canal. So this is an ideal case. It's an easy and ideal case of a 73 years old female with a claudication, mechanical low back pain, some diabetes, anticoagulation, obesity. If you look at the left lower CT, she's quite an obese lady. She has a degenerative listhesis by L4-5. And if you are looking at this picture in the aspect of the degenerative, for the indirect decompression, there are good signs. Good sign is a collapsed disc. Good sign is a listhesis. Good sign is a still mobile segment and the vacuum phenomenon on the disc and also in the facet joints on the right side. If you are looking at the compression-related good sign, there's the disc bulge, which is going to be important because this is what is disappearing. Also the hypertrophy of the ligamentum flavum, yellow ligament, without ossification, and also the foraminal stenosis, which is reacting really well to the indirect decompression. So this is what you get. This is a single position lateral, easy surgery. And this is the lady after 3 months. She is 2 years out now, and she is quite happy with that. It also opens up new possibilities because there is the possibility to have a patient do the anterior support and reconstruction, let them walk a couple of days, see if the claudication radicular pain is gone, and do a second surgery just as a simple percutaneous technique. Or you could just, like in this case, you could do a hybrid. In this case, there was like at the level L1-2 an instability and the ligamentum flavum calcification, so it did not react well to the indirect decompression. You see the MRI in the midline. It's still pretty narrow, and also the foraminal stenosis is there. So we did a hybrid technique with opening up at the places where it was needed. So this is how it looks. The decision making is quite shocking at the first picture, the first look. These are the 11 things we are looking at. Disc height loss is clear. Listhesis is clear. This is a good indication for indirect decompression. Disc bulge is important. If there is disc bulge, it will be answer well to the indirect decompression. You need to ask the question, is 2 to 3 millimeters going to be okay? Is that going to be enough? If you have a hypertrophy, and with the hypertrophy ligamentum flavum only 5 millimeters, probably an increase of 2 millimeters won't be enough. Calcified ligamentum, yellow ligament is indirect direct decompression reason. Foraminal stenosis indirect. Disc herniation is always a direct decompression, and it has to be a mobile segment. If it's ankylosed, probably it's a better to do a direct decompression. And with that, we could conclude that indirect decompression is not an universal tool. Patient selection is the key, and the risk of revision with direct decompression is small. You have to discuss with the patient before the first surgery and decompress it directly if there is still some complaints. That was it on my side. Thank you.
Gregory, thank you very much. I think that was an excellent summary. I reckon that for the purpose of the debate, you're almost sitting on the fence there, you know. And I like your list of criteria when to not do it. I think that keeps you very safe. You know, what I'll ask is, in your experience, do you ever push those indications? You know, I think, you know, to me, you know, there's a degree of calcified yellow ligament and sort of, you know, perhaps disc, you know, problems that you can accept, right? So, yeah, particularly like a disc herniation if you're doing an ALIF, because you can kind of get that from the front. Now, whether that falls into direct or indirect decompression is a topic we can discuss a bit later on. But, you know, I think this is a great chart for people starting out with this. But, you know, have you found when you push the indications that it gets better, or what's the situation?
I mean, we try to stick to this way of deciding if it's going to be good or suboptimal indirectly, and this is just a way for you to treat the levels. And there are some levels where you have to do a decompression, and I mean, spondylolisthesis is just the best example, either lytic or degenerative, because with the reconstruction of the disc height, you are usually doing the reposition and also lower dosing this segment. So these are the nicest cases. We just do an ALIF and do percutaneous screw placement in most of these cases, low grade spondylolisthesis. There's some drawbacks. We had patients with disc herniations, with neurologic problems after the surgery, but it's really rare. This is, I mean, it's coming back to the classical, if you select your patients well, they are going to have a good answer to the indirect decompression. But it's not a universal tool. This is just like the chronic slip. It's not for everyone. It's not for every patient.
Okay, brilliant. Well, look, what I might do is get Samir to do his talk now. Hello, Samir. Nice to see you. I think what we'll do, if we can, yeah, put the Europeans first. It gives you guys a chance to go to bed. Thank you for staying up late and joining us here. So I'll get you get you in and get you talking, and then we can talk a little bit about birthies and give you guys the option to peel off. We won't say anything bad about you when you're gone. If you have to go to bed, we understand. Okay.
Mike, I have a question to Gurgly before Samir, as Samir pull up his talk. Gurgly, great talk. So for the 2-3 millimeter rule you just put up, is there any data on the impact of listhesis reduction on the size of the canal, and can we come up with a way to methodically say, well, this is, I cannot do it indirect because it is this amount of listhesis is there versus canal compromise?
The listhesis is always a good indication, because usually you are going to reposition partly the listhesis. Usually, I mean, in low-grade listhesis, the grade 1 is going to be an anatomic reposition. Grade 2 is going to turn out to be a grade 1. So it's like one grade you can reposition. And it's always good for central canal. I'm not aware of any studies on that. Most of the surgeons are not happy to treat spondylolisthesis indirectly, which I do not know why, because if you have a grade 2 listhesis and reduce it to grade 1 and indirectly decompress your foramen, and the nerve pain is gone, and you do not have any stress on the posterior instrumentation, you just put in percutaneous screws, and this is the best way to, and also minimal invasive way to treat these patients. There are some articles with data on effectivity and complication rate, and this is similar, but there are less just studies with small number of patients, about 30, and so. And they usually measure the area of the canal, and which is increasing. I haven't heard about this 2 to 3 millimeter rule, which we just, as we said, made up. But this is what we always see. I mean, I'm not always sure about the ligamentum flavum. In Germany, you cannot do an MRI like on every patient postoperatively, but on the ones we did, this 2 to 3 millimeter decrease of the disc bulge was always there. So this is why we are going with this. We are shooting for the. This is why this question is important. Would the 2 to 3 millimeters be enough to have a sagittal diameter from 5 to 7 millimeter? Because usually that's enough for most of these patients.
Right. Thank you. That's awesome.
Awesome. Well, let's get Samir in, and he's going to have a chat. You got some cases for us, Samir? He's got a little bit of rationale as well. Excellent.
Good evening or good morning, ladies and gentlemen. It's my pleasure to welcome you to my presentation on this important topic in spinal surgery. As you are experts in the fields, you are undoubtedly aware of the significant advancements and ongoing debates surrounding minimal invasive techniques. And I'm thankful that you're joining us today, and I look forward for engaging and informative session with all of you. So, what is indirect decompression? It is a surgical procedure often used to treat spinal problems such as stenosis, herniation, or instability. Unlike direct decompression, which involves direct relief at the affected site, indirect decompression aims to achieve relief through structural changes. Here are some arguments in favor of indirect decompression. So, first of all, minimal tissue damage. Indirect decompression procedures are generally less invasive. requiring zero direct manipulation of the spinal canal and nerves. This results in less tissue damage and reduces the risk of scarring and other complications. In this study, there was a conclusion that there's more muscle damage in open TLIF than in minimal invasive TLIF, that we all know. And in this study, there was shown that an XLIF procedure is advantageous to minimize blood loss and muscle damage. So another important factor is the shorter recovery time of patients. Since these procedures are less invasive, patients often experience shorter recovery time. This means fewer hospital stays or maybe ambulatory surgeries or quicker return to normal activities. In this study, it was concluded that an OLIF has minor intraoperative trauma and quick postoperative recovery. With less tissue damage and less invasive techniques, postoperative pain is usually reduced. This can decrease the need for pain medication after surgery. Nice meta-analysis showed the conclusion, besides other conclusions, that the shorter hospital stay and superior improvement in postoperative pain and ODI scores was shown. The preservation of spinal structures is a very important thing to my mind when we look at indirect decompressions. It is of crucial importance for muscle function and long-term reduction of ASDs. Here's an example of mine, how you can see that postoperative, you don't even have any muscle damage at all. So when we see TLIF procedures, we usually see heavy damages around the paraspinal muscles and the multifidus. So there is a lower risk of cage subsidence because when using indirect decompression techniques, we usually go from the front and have big cages, which helps us to reduce the risk of cage subsidence. In, for example, open TLIF or minimal invasive TLIF procedures, we have small footprints, and therefore there's a higher risk of subsidence. And with subsidence, we have a risk of a stenosis, a restenosis again. An in vitro comparison of end plate preparation between 4 mini-open interbody fusion approaches showed that the XLIF approach resulted in the greatest relative area of end plate preparation. The percentage of end plate that was deemed to have complete disc removal was the highest in the XLIF group, with 90% compared to 65% in the MAS TLIF group. End plate damage area was highest in the MAS TLIF group at 48% and lowest in XLIF group at 4%. And XLIF resulted in the greatest end plate preparation and least end plate damage. And a nice combination, like when we use these indirect decompression, we get the most modern techniques to use, and it is like very nice when we can use these techniques. We can play with the patients from the front, from the back simultaneously. And we never go into the spinal canal, and we do this all without affecting the nerves, and still we can do great decompressions at all. So here on the X-rays, you see from anterior, like how the indirect decompression works. So we can restore the height of the disc space, and therefore we can elevate the neuroforamina. And the middle video, we see in typical XLIF, and we see how the disc space is restored, and therefore the ligaments in the back get stretched, and we reach decompression through stretching the ligaments.
Hey, Samir, I'm going to interrupt for a sec. That is an awesome video. But you know that little osteophyte you see off the back of L5?
Yeah, I see it.
I love the lateral A-lift technique, but you know, sometimes when you do a supine A-lift, it's nice to be able to just sort of shave that a little bit. It makes me feel better. Do you reckon in your follow-up those will reabsorb?
Of course, they get all all follow-ups, and you can in a lateral A-lift you can take these osteophytes away like in supine A-lifts, to my mind. I think Gurgly does the same. There's no problem to reach the neuroforamina usually.
Mike, what tool are you using to resect those?
Oh, I just use, like when I do an A-lift, I do mine supine, so it's like a giant ACDF. So I just use a Kerrison and curettes basically, and just take down the PLL. I mean, I see the dura side to side. It's part of my philosophy because I think by taking the PLL, you get a physiological sort of decompression basically, because a lot of time to me, the PLL is part of the issue is that it's contracted. But yeah, if you then put a big cage in the front, it pivots around the PLL rather than actually giving that physiological restoration. And I reckon before I did that routinely, at least significantly loosen the PLL or take it completely, you know, you end up with a few patients that get that superior articular process digging in at the back when you use lordotic cages. So it's changed my rate of that happening, I reckon. But
I released the PLL on all my A-lifts as well.
as well,
There's
interesting.
like two things. Sorry, with this osteophytes. There's and I think this is what we learned in tail lift surgery, that we usually see that, and it was a problem. And nowadays, I don't really think that it's a problem. We need to differentiate between horizontal and vertical foraminal stenosis, because if you have a horizontal foraminal stenosis, it won't get better due to the indirect decompression, increase in foraminal height in vertical.
Unless you're reducing a spondy, right? Because then you can fix front back stenosis.
Exactly. But that's the spondylolisthesis, yeah. And the second is there is one article from Bach, senior author was Uribe, and this is about the posterior disc height, and this became for us really important, because if we are going for 5 to 6 millimeter posterior disc height with the X-lift and also with the A-lifts, then usually the foramen is open, so you won't have to worry about the superior articular process impinging on the nerve root anymore.
Sorry, Samir, we interrupted you there, but that's part of this meeting, so I'll let you keep going.
Yeah,
Okay.
that's it. Sorry.
This kind of let's say this kind of surgical technique is so suitable for certain patient groups. For example, for older patients, for patients who are very sick and need a quicker surgery or less invasive surgery, is quite interesting technique and maybe favorable. And even for the really heavy ones, which we really do not want to perform a surgery on, it's a good technique as well, to my mind. So why I use decompressions? Why I use indirect decompressions? I believe this study is a very important study for us. After 2 years following up these patients, like every couple of months, showed that the decompression even develops better and better. So the ligaments get thinner, the bony, not the bony, the how you call it, the flavum gets thinner. Everything gets somehow smooth in the spinal canal. So after 2 years, where there is some end of, let's say, development of opening the spinal canal, we see really beautiful pictures. And this study confirms even my let's say, clinical observership. So there are So the predictors, which surgery is the most, I would say, most successful surgery? Which kind of predictors do we have to say, okay, a lateral lumbar interbody fusion, indirect decompression is better than a TLIF or something? So usually the lateral lumbar interbody fusion is successful when there is when there is central spinal stenosis or neuroforaminal stenosis, low body mass index, and some preoperative spondylolisthesis, which results into spinal canal stenosis, and when we have a certain disc collapse. I think these are the best candidates for surgeries. So patients who have a normal disc height and a severe central spinal stenosis, I think these are the worst candidates. I would never do an indirect decompression in patients with normal disc height or without an spondylolisthesis with a severe spinal canal stenosis. I mean, I think this is maybe the most the worst patient you can use for indirect decompression. That's all about my talk. I'm sorry, I'm so tired tonight, and well, I'm gonna go to bed. We'll leave you after this presentation because I need to do a couple of surgeries tomorrow.
Samir, no, we really appreciate you coming on. We know you're a master surgeon for this, so yeah, we'll let you get to bed. Thank you for staying late. You know, Alexander, who's part of our global spine panel, he's pretty good. He does this most months, so it gives us an appreciation of him doing it tough in the middle of the night down in Switzerland. So yeah, excellent. Well, what we'll do now is we'll just move on, and now that our Europeans friends have had their say, we might hear from Alan and Basil, whoever wants to go first, because I think we now need to hear about why direct decompression is better. Thanks, Alan.
Yeah, my pleasure. Sorry, guys, I got a little laryngitis here, but I'm really excited to be here. Thank you, Mike, for inviting me. So these two talks were spectacular. My first disclaimer is that in my practice, I fixed a lot of failed indirect decompression. Patients like this who've come in, attempted indirect decompression, residual stenosis, the level above, and that foramen requiring direct decompression, revision fusion. So I'm a bit jaded. Also, these are some of my recent LinkedIn cases. I just want everyone to be reminded that spine surgery practice is very wide ranging. Take care of deformity, cervical non-unions, scoliosis, PJKs, fractures and fracture non-unions, severe trauma, tumors, people with severe OPLL, and extruded discs. And none of these are appropriate for indirect decompression. So I think that the first two talks were great at highlighting the types of patients we can treat with indirect. But here's a typical office day. This was today in my office. And well, maybe this one patient is appropriate for indirect, the rest aren't. There's one. So what does the data say? Well, as stated earlier, you've got to have change in alignment. You've got to have some structures which can either be stretched or reabsorbed. There are benefits, but I believe they're short term. The lateral interbody complications are real, and prolonged radiculitis is real. So I won't beat a dead horse. The last talk highlighted this well. You've got to be able to increase the disc height or reduce listhesis. Those patients are relatively rare. Furthermore, when you do increase the disc height and reduce the listhesis, there's certainly risk of subsidence. And so basically, as stated, if you use large interbody cages, your risk of subsidence is low. But we have masters here who are talking, and you have to keep in mind that some people in the community may not be quite as good at using appropriately sized cages. So that's why I sometimes see patients referred in for failed indirect decompression. What about reabsorption? Well, you have to have some sort of structure that's stretched to reabsorb. So patients like this with calcified discs or thoracic discs, not candidates. What about the benefits? Well, here's a nice study out of Global Spine Journal looking at MIS versus open, showing that there was quicker recovery, less dissection, no difference in outcomes at 1 year. Another nice study, same thing, 3 months, some improved quicker recovery, no difference at a year. How about lateral complications? Well, I've seen them in my practice and others and locally. Retroperitoneal hematomas, ureteral injuries, rib fractures, hernias, renal artery injuries, aorta injuries, necrosis of the solid organs, ischemia, bowel perforations, aortic perforations, pseudoaneurysms, and they all happen. And so again, in a highly skilled surgeon, your rates may be low, but to be promoting the techniques, I think we have to be very careful. What about radiculitis? Well, for any busy spine surgeon, to have a patient come to your office with a severe radiculitis is really annoying. That's all there is to it. You're constantly telling them they're going to get better. You're constantly giving them steroids or medications. You may be ordering injections. You may be doing physical therapy. But it is such a frustrating experience for a patient. And this study said that in open decompressions, motor function and rates of radiculopathy were lower in the open group than MIS. And I don't do a lot of indirect decompression, but I've had a couple of severe prolonged radiculitis that did go away. For a record, they did go away. But I got to tell you, it was a couple months of extremely annoying phone calls to me in my office, and coaching them through it when I could have just done a simple, small laminectomy would have been beneficial. So some real world cases from my practice, 76 years old, L4-5, low-grade listhesis, relatively preserved disc space height, but a grade 1 listhesis. And you see these humongous facet joints. To me, is somebody out there that may want to do indirect? Of course. But an extremely simple, open, Lamy fusion, no cage. This patient did great. Small incision, rapid recovery, low cost, low risk. What's the point of indirect decompression? For this patient, 71 years old, critical stenosis. Everybody knows that needs an open Lamy. And yet again, simple operation, multi-level Lamy. This patient's 2 years out, ugly spine, but doesn't need some sort of multi-level lateral fusion. So why should we use direct? Well, it's reliable. It works. Complication rates are very predictable and low. We have very low reliance on technology. Don't forget, this is a global forum. Not everybody has access to advanced lateral retractors, cages, neuromonitoring, BMP. Now, you may say you don't need all of those things, expandable cages, but a lot of people are using them for these minimally invasive techniques. Cost is important. I don't think any of us should forget about that. Healthcare is bankrupting the United States right now, and is expensive in other countries. So we should think about cost. Doing lateral cages is expense that may not be needed. Also, with open spine surgery, we can take care of essentially every problem in spine, not just a tiny fraction that indirect can do. And I beg of you all, don't forget to keep up your decompression skills. We're spine surgeons, we manage dura. It takes practice. You've got to keep doing it to be good at it. So there's my office day. And there's Peter Derman looking for a needle in a haystack, find the perfect patient who needs an indirect decompression. I'd prefer just to offer people a solution I know that works. Thank you.
All right, I have some questions. I've been taking notes, Alan, on your talk here, which I appreciate very much. Clearly, we have very different practices, and I think that's, everyone has to do what works well in their practice and their patient population. So you can't none of us can make sweeping statements, but I will say, the fact that, you made a statement that a patient with spondylolisthesis and degenerative disc disease is a rare patient. That's like one of the most common patients that's seen, certainly in the United States, and operated on by spine surgeons. So I wouldn't say that's rare. Maybe that's rare in your practice, but for the rest of us, that's like the most common reason that we're doing instrumented surgery on these patients. And so, I think that the vast majority of them do very well with indirect decompression. The other argument, which is made frequently, kind of justifying more traditional techniques over minimally invasive techniques, is, well, it's the same at a year. Well, if you had the option to have an operation and go back to work 3 days later, or 3 weeks or 3 months later, and you're the breadwinner for your family, or maybe you're the one who takes care of your kids, and somebody said, oh, don't worry about it, at a year it'll be the same. That's not a great argument, in my opinion. Furthermore, this destructive surgery, maybe at a year these patients are fine, but at 5 years, I bet there's elevated risks of adjacent segment disease, because you're destroying the posterior tension band. So we've picked a time point where things seem to be equipoise, but we're ignoring the year of misery leading up to them and the problems down the line. So I really take issue with that argument that a year everything's the same. And then the last thing I wanted to mention is that in case 1 that you showed, which was a subtle, stable grade 1 spondylolisthesis with no facet effusions, no facet cyst, another option would have been just a decompression. So a minimally invasive midline sparing decompression has been shown to be non-destabilizing. So as a member of team indirect decompression, I probably look at the dura more than anyone. 70% of my patients are isolated decompressions. But if I have to fuse somebody, I'm going to try not to have to decompress them as well, because it's just unnecessary surgery in the vast majority of the patients that come to see me.
Yeah, those are great points. I think you're right. Spondy is common, but the patients who are perfect for indirect, I think, are less common based on the algorithm that Gurgley had that was great. What I would say about the 1 year, I was trying to present some real data to show what we have. I would tell you that at least the patients in my practice are back to work quite quickly. And I think that this is just a call to arms for all of us to continue studying this problem and really show that some of those downsides of indirect, such as decision-making cost, the risks, which we all may admit are maybe relatively low, especially in experienced hands, are worth it and are meaningful. And I think Dr. Debo is actually going to give some talks on some of the longer term ramifications too. And so I appreciate the opportunity.
I think Peter should go next. He looks ready for it. What do you think, Mike?
Oh, look, I think we can.
I only have a couple. I'll show my slides.
Yeah.
It's only a couple additional things, and it might be helpful to show mine real quick if you don't mind.
Yeah, for sure.
Let's let Peter in. I think that's a great idea. Tag team in the ring. Go for it.
So let me share real quick. And it's nothing dramatic to add, just a couple of kind of my thoughts. So indirect decompression does the trick. Same stuff everyone said. Why do we do indirect? It's faster, less anesthesia, less morbidity, less risk. There's tons of studies to support indirect decompression, like tons. There's imaging studies. Here's just a small sampling. There are clinical studies that support this too, and I don't want to belabor the point. We did look at our own series of ALIFs at Texas Back Institute. We looked at like 600 or 800 patients, and the need for return to the OR for direct decompression was less than, it was like 4%. So that means that if I'm doing direct decompression on this subset of patients, that I'm doing too much surgery on 96% of my patients. I just want to highlight 2 of my favorite studies about indirect decompression, and this was kind of in the chat as well. So this first one is a Greg Mundis study where they looked at rest pain as a predictor of success of indirect decompression. And this is one of those very simple studies that like very quickly changed my practice. And without going into all the details, they basically looked at whether patients had rest pain, rest leg pain, and then stratified those patients and looked at how they did with indirect decompression. And patients basically with minimal rest pain tend to do very well with indirect decompression, which makes sense, right? Because ultimately, all they have to do is change the position of their body, and that's enough to take the pressure off. So, we had talked initially about the 2 millimeters, and is the 2 or 3 millimeters enough? Ultimately, it doesn't matter how many millimeters it is, right? What matters is whether or not they get relief. And if all a patient has to do is go from standing to sitting or standing to laying down, and that's enough to give them the relief, then we should be able to give them that in the operating room. And therefore, indirect decompression tends to be quite beneficial. So that's a question I ask all of my patients Do you have rest pain or not? And that's the key factor that I actually use when considering indirect decompression. One thing that used to scare me on indirect decompression was these foraminal bone spurs. So, I think indirect decompression is a great solution for up-down foraminal stenosis because you lift them back up. It's a structural problem and you reestablish the foramen. But some of these people, especially say at L5S1, have these big giant foraminal osteophytes coming off. And I worry about tethering the nerve and creating like a stretch radiculopathy, kind of like what Alan mentioned. Chevy Iyer out of HSS, one of my friends, came out with this study recently, it was this year, looking at TLIF versus ALIF without a direct decompression in the presence of these foraminal osteophytes, and actually found that the rate of improvement in VAS leg and ODI was really identical between the two techniques, and didn't matter whether or not there were these foraminal osteophytes or not. And so, seeing this study has also pushed me toward doing indirect decompression even when I see this. I am, when I see this, more cautious, although I'm always pretty cautious about not overdoing the posterior height. Like we were talking about, Mike, I release the PLL on every case from an ALIF, and you can really put whatever size cage you want in at that point. And so really, I measure the preoperative posterior disc height, and I just add a couple millimeters, because that's usually all they end up needing. But this has pushed me away from direct decompression in the setting of this kind of pathology if I'm doing a fusion. And then this is really my algorithm. It's very similar. Really my question is, can I change the spine? And if I can change the spine and the patient feels better when they have they sit down or lay down, then I should be able to give them the relief that I need. So symptoms improve with rest, that's indirect. Spondylolisthesis, collapsed disc space, decent bone density. Some people have touched upon subsidence. And so I did a case recently. The woman had not great bone, and I knew that I was going to be very conservative on my cage height. So I did a direct decompression in that case because I couldn't really do the work that I needed with the cage. And then, large facet cysts, that's something we haven't talked about today. I think this is actually an interesting nuance that I'd like to get other people's thoughts on. If they do have a big facet cyst, I tend to take it out. There is some research to show that it will resorb over time, but I don't really want to wait long periods of time if it's a big facet cyst. It's a small facet cyst and it gets better with position, then I might leave it alone. And then free disc fragments, that's why I have maybe in there too, because you can sometimes fish them out from the front if it's an ALIF. So that's kind of plus or minus. And that's kind of, my thoughts on how I think about direct decompression. Very similar to the other guys, maybe with a couple additional nuances.
Yeah, Peter, I really love that study. I hadn't seen that one yet on the front back stenosis with that foraminal restoration, and that's always been a bit of a concern of mine. And definitely when I started doing hyperlordotics, I had a couple of patients where that superior articular process was digging in. But then, as we were talking about with ALIF, I did find that those were addressable generally by a better release of the PLL or taking the PLL completely and getting that posterior disc height up. I don't know if anyone else saw this, but Juan Uribe was talking about that you only need 6 millimeters of posterior disc height on average in most patients to restore the canal, which I think is really important data. You don't need to go stuffing massive cages in there. Get something appropriately lordotic and get about 6 millimeters. I don't know if other people have seen that as well, but that's certainly been my experience. So we're going to let Basil go. We're going to go back and forth here. He's going to get in the ring and give a few shots for Team Brown. Thanks, Basil.
Yeah, of course. Comment on Dr. Uribe's study is driven by a lot of anatomy data, looking at what the average posterior disc height in humans, and the most on the average was about 4 to 6 millimeter. It varies by the segment where you are. From bottom to top. So I agree with him. We've seen it in a couple of our studies as well on our data. So thank you, everybody. Those were awesome talks. To Peter, I would say, Alan showed data 1 year, but you made an assumption of 5 years. So maybe if you have a 5 years data on adjacent segment disease, we'd love to see it. MIS versus open. And for that, I think what matters today, and I'm gonna kind of shift gears to talk about something else. Non-direct or direct decompression, I'm going to talk about segmental lordosis restoration versus focusing truly on distraction of the disc and foraminal height obsession. At the very end of the day, we're technically most of us are orthopedic surgeons, and restoration and carpentry of that segment is really important. This is my disclosures. First off, I'm going to show you two indirect cases that could be properly planned and done well. This is actually the way Alan and I do it here at Brown. The 73 male, progressive low back pain, unresponsive conservative measures. MRI will show central neuroforaminal stenosis indicated for 4.5 and 5.1. There's a lot of back and forth will be on pelvic fixation versus now on this case, but that's just for the sake of the conversation. This is two-level spondy. We do plan our surgeries, direct or indirect. We do feel that in order to decompress the neuroforamen and achieve proper decompression, at the same time, you need to kind of think about what is the proper alignment for that segment as you finish up the case. We really rely on pelvic incidence for that. We check every single segment we operate on or indicate, and then we kind of choose the alignment associated with it. So this is really just a simple table that we published in JBJS recently. It's rather rudimentary, I would say, simplifying the process. Obviously, cutoffs are not the end all be all, and it's obviously a range, but we try to aim for those, shoot for them, and not shoot too higher than that or too lower than that. So if we indicate L4, L5 and a PI of 50, 60, we kind of choose those segmental lordosis as part of the planning. So we go really in details. Not everybody needs to kind of go in that, but at least if you know exactly what you're targeting in terms of segment, and then you plan your posterior height and factor your lordosis, you kind of choose the proper cage for that. This is the way we do it. This is the anterior ALIF approach, restoring the segment as we planned it, as we based on the recent data by normative patients from the SFSER and the French Society, and then we go to the back and just lock it in. This is pre to post. And it's not, oh, this is an open case, obviously. This is, you can call it hybrid like Neil Anand does. But this is another case, for example, 42 years old, progressive back and leg pain, L4-5 spondy with rheumatoid radiculopathy. This is one of our partners. Actually, it's not my case, but it's a beautiful case showing how indirect decompression could properly do the job. This is the segmental analysis. Again, PI of 52. We know the segment has to be between 17 and 20. So we get in there. This is the MRI. It's going to go to the 4-5 segment and show the stenosis. Obviously, severe central. The surgeon believed that indirect decompression would restore the canal, which was appropriate, as well as the foramen. But in the same time, L4, L5 segment was restored all the way 16 degrees. Even Peter showed a case nicely restoring that segment as well. So I'm just trying to target this angle. We don't forget that this segment not only need to live, 3 months or 1 year, it needs to live longer than that. Spine surgery has to come to a point where it is kind of similar to total hip replacement, or at least total knee replacement. At this time, it's really not. This is pre to post, a beautiful indirect decompression, perk screws in the back, as well as restoration of foraminal height. Now, the truth is, you pick what you want to decompress to the root, but the more indirect decompression being done around the world, the more interbody reliant procedures there is. And if the procedure interbody reliant, then the interbody has to be really perfect, because there's a risk of overcorrection and undercorrection. Even knee surgeons talk about stuffing, elbow replacement talk about stuffing, or radial head issues. You cannot overstuff something, and the same thing in the spine. The lumbar lordosis has a certain threshold to it. Below or over that is just non-physiologic. And the additional point here is, if you rely on direct decompression and choose your cages, and then you go to the back to perk, if you missed out on the cage alignment, then your rod is not going to save you, because we often, or whomever does indirect decompression and MIS in the back, they often just slide the rod that fits the screws. So you are kind of, it's double whammy. This is, for example, cases of indirect decompression, or some of it is, but in general, it's poorly restored segmental lordosis. So if you do like indirect decompression, you must love alignment then, because otherwise those patients could end up something like that, which is actually the best ever for this talk. This is a combination of direct decompression in the bottom, indirect decompression up top, and the most horrible sagittal plane ever. This patient is not going to survive 5 years without adjacent segment disease, nor one. Obviously, this was about 4 months follow-up, seeing somebody in a practice. So,
Hey, Basil, I'm going to jump in there. Basil. That X-ray, the patient's had a laminectomy. You can see it on the midline.
The bottom.
So they've had a direct
So the bottom is
decompression.
direct, the top is indirect.
Okay. It looks like they've had a lami going further up as well. But yeah, I agree. The very top. Okay, I get you. That one there has gone horribly wrong. Good.
So that's that. And then because the spine has a shape like every other bone in the body, there's shape to it. There's a lot of ways to plan alignment in every segment. In the degenerative world, you don't have to fuse long to restore alignment. You can just restore that segment you indicate. And this is a very beautiful study by Ella Bean, one of the very few in literature showing how lordosis could come from the body and the disc. And it really take an intricate planning that you need to spend 5-10 minutes just to know exactly how much how big of that cage you're putting in, just the way you're planning your posterior height. So we do like restoring the shapes, and this is again the way we do it. We do have a study that's going to be at Podium and NAS, and we have a couple an SRS and LSRS talking about this and validating it. So it's real data. It's showing good results. Thanks so much.
Basil, thank you so much. That's very, very well presented. I think we've had a few arguments, and we'll just look for some questions from the audience. I got a question from Matthew Burchuck, who's online with us, about would you ever do indirect type decompression in the presence of a motor deficit? I'll put it to the panel because we do have David Yam's talk. He had to pre-record, and so we can add this to the presentation later on and put it on YouTube, and I'll promote it up on LinkedIn, because I think it's good. Probably we have 5 to 7 minutes of discussion now, rather than running horrendously over time. I know it's really late at night over in Germany, so we'll would anyone ever look of the indirect decompression fans at an indirect decompression in the presence of a motor deficit?
I would, especially for foraminal stenosis. That's where I'm the most confident I can open things up. Canal stenosis, how much ligament is going to stretch, how much is the disc going to suck in, we don't really know always. And so in the presence of a motor deficit, we really need to be sure that we're maximizing chances of success. But in a collapsed disc space, the concavity of a curve, spondylolisthesis, I know I can reduce, then there's no reason to do a direct decompression there for the foraminal stenosis.
Yeah, look, in the spondy setting, particularly say 5-1 with a mild motor deficit, I would definitely agree, and I just go anterior or lateral if it's a bit higher up in the spine. I think for any central disc herniation or a facet cyst, which is what Peter was alluding to before, I think a facet cyst with a motor deficit, I would directly decompress that. It's one of the few times that I will try, look at Dura when I'm fusing people these days, aside from big multi-level stuff where I'm doing Pontes. But, this is I think facet cyst is something that without deficit is something that does really well with indirect decompression. I've got so many MRIs of them just resolving afterwards. And so, as long as you get stability, and I think that's the one thing that I've found is that if you're going to choose to do an indirect decompression, you have to make sure you get a good fusion. Yeah, and I think that's the key, because I reckon a lot of indirect decompressions fail because there's a pseudarthrosis or a delayed union there. That's my theory.
Same here. May I just get back to some points of Ellen? If you are looking at the overall complication rate of open tailif, and I was a tailif guy. I was like one of the last Mohicans of Jürgen Hams, so we did learn how to do a tailif. But the overall complication rate is 24% for the tailif and also for the transverse fusion. So it's basically the same. What we really realized, we had to realize that the patients treated with the lateral fusion or ALIF, they just stand up the next day, which was for me not believable in the first couple months, as we just flipped And because of the high complications in TALIF in patients with poor bone quality over the years of 75, this is basically our biggest change. We are just doing lateral interbodies because they are not subsiding. And also this is like I'm not using standard neuromonitoring for all of the cases, so I also saved the 800 euros. But for us there's a big difference between the open cases and the minimal invasive laterals in recovery and short-term recovery, just to talk before Peter.
Hi, good evening or good morning. I'm David Yam. I appreciate you having me on here for this very easy talk about how indirect wins. These are my disclosures. So Mike Selby invited me on this talk and was kind of talking about how it's going to be a nice, friendly virtual spine conference, and of course it devolved into this nightmare. So here I am with my Mad Max style defense from my position. On indirect decompression. This kind of concept was pioneered by Luis Pimenta back in 2001 and 2008. And the concept was simple: just remove disc, place a taller spacer, stretch the ligaments in the space, and make additional room for the nerves. And back when I started doing lateral surgery back in 2010, this is sort of what it felt like you were joining the dark side. Fighting the direct decompression folks, but obviously things have changed. Now, of course, this isn't the history of indirect decompression. This is just the most recent form. Indirect decompression actually started much earlier, and two guys, Smith and Robinson, with their ACDF in 1955, had the same basic idea: take out a collapsed disc, put in a taller spacer, stretch open the spaces, and avoid posterior surgery in most cases. And that was the idea. We've been doing this successfully for a long time. We all would probably regard ACDF as an excellent option for patients. And almost no one would argue that posterior decompression infusion is less invasive than an ACDF. So they did find two people that are willing to do that, but that's pretty hard to do. So why has the concept of indirect decompression struggled a bit? Well, it's a newer procedure, newer concept in the lumbar spine, and the early adopter phase has been sort of in the phase we've been in for a long time. Decompression has always been the mainstay, so it's already been through this entire curve, picked up everyone, and so it's hard to change something that is the mainstay. And complications with 4-5 and whatnot had sort of held back lateral surgery. So the graph maybe look more like this. And then TLIF has always been a great procedure. It's very versatile, and you always get amazing results with TLIF, but I would argue there's a lot of asterisks there. And some of these asterisks are just that, TLIF, the argument's made that TLIF cases always fuse. Of course, that's not true, and that pseudoarthrosis rates are higher with TLIF than ALIF or LIF. If you look at kind of the data that's out there, some people say they've never gotten a CSF leak, but 3.2 to 18.5% of cases have some type of durotomy or accidental durotomy that occurs during a TLIF. There's the argument that TLIF is fast and efficient and I rarely have blood loss, but if you look at, again, some of this data that's out there, significantly higher rates of blood loss and longer operative times occur in TLIF versus any indirect strategy. And then there's the argument that you always have to decompress anyway, so why not just do a TLIF? And that's sometimes true, but it's not always true. And I'm going to make that argument today, that sometimes it is not always. So a deeper dive into that last paper. It's a meta-analysis of 1,004 patients, and if you look at the outcomes were similar between the indirect and the direct group, but the complication profiles were very different. There were 31 dural tears, 8 surgical site infections, and 2 epidural hematomas in the direct group versus 0 of those things in the indirect group. And it starts making things seem like, Well, if you're having significantly more blood loss and more operative times, it starts looking kind of like this. And you see this hospital where the floods, there's a flood occurring from the CSF leak in room 3, and the bloodbath coming out of the Otis elevators and into SPD from these types of complications. And trying to avoid complications is a very important goal, in my opinion, as a surgeon. So one of the counterpoints that you'll always hear is, well, I might have to take the patient back and decompress them. And there's some papers out there that will throw the super high numbers at you. But an experienced lateral surgeon like Ribe, publishes a 6% rate. I believe the rate's actually even lower. And you really should be careful listening to the opposition's pie charts and formulas from their random papers that are probably misleading. If you're having a 50% take back rate, you're probably not selecting appropriately, or you're doing something that surgically is incorrect with this procedure. So the other common counterpoint you see is that surgeons will say that they're really good at TLIF, and admittedly, there's a lot of really good TLIF surgeons out there, but my argument for this would be is that if you're really good at TLIF, you're probably also a gold medal candidate for a lateral lumbar interbody fusion. The surgeries are technical, but TLIF is likely more technical, again, there's a good chance you can be great at both, which benefits your patients. And your patients potentially receive the biggest buzzword in spine surgery right now, which is more lordosis, right? They also get more disc height restoration. Traditionally, they get more foraminal height restoration. They get easier coronal corrections. And there's also a trend towards shorter lengths of stay. These are all positives for your patients. So a real quick case, a 65-year-old male with those body habitus numbers there. And the only time we can poke fun at our metric friends is that they might measure life in seconds instead of years. But anyway, no prior surgeries, relatively healthy, 10 years of progressive back pain and failed conservative treatment with a high VAS and new onset weakness and claudication. And here's some pre-op x-rays showing the spondylolisthesis, no pars defect, and some severe disc collapse at that segment. And here, pre-op MRI showing a very tight canal. You can see the stenosis is severe. You can see the disc bulging and the facet arthropathy as the causes. So, my questions here are, do you want to do a surgery that has a higher CSF leak rate, higher epidural hematomas, more blood loss, higher rates of infection, lower rates of fusion, and longer operating times when you can do a similar operation for the same symptoms and get a similar outcome? And my answer is, of course, no. I would hope that most of you would agree. So here's this patient's intraoperative films. We did a partial reduction percutaneously and then put a lateral spacer in sort of ventrally because of the femoral nerve location, but able to sneak in a cage and also get some disc height restoration for this patient. And here you can see the post-op and follow-up images of this patient. He had a short length of stay, VAS improved quickly, walking improved quickly, and no direct decompression was required. That these things help patients to get home quicker. You worry about them less. They end up doing quite well. And even in severe cases, again, don't necessarily need decompression. So when to consider direct decompression? Well, if you're not doing a fusion, do a direct decompression. That seems like a pretty obvious statement, but there are some other considerations that you might want to weigh. And this list here shows patients that might benefit from a direct decompression on the front end. those patients with severe osteoporosis or high risk of subsidence, because they'll lose their indirect decompression. And similarly, if you damage the implates or you notice subsidence intraoperatively, it might be a great idea just to consider doing the decompression. And I add that to the consents every time to make sure the patient can have the surgery they need at the time of surgery without a take-back. Patients also that have taller discs to start with. Those patients won't get a lot of stretch, so you may want to consider decompression directly. There's also a small subset of patients that have super severe stenosis that I think benefit from decompression, or those with cauda equina and major motor deficits that you don't really want to sit around and see if they're going to improve. So there are some patients that benefit from direct decompression, admittedly. So for literally almost any other fusion, you might be able to do an indirect decompression with a potentially higher success rate, as we've discussed today, and also a better complication profile. So I'd like you to think about your next redo TLIF that you're booking and decide, is it worth dissecting through all that scar? Think about your next very deep patient. Think about your last or your next dural tear and what you have to do to manage that. And think about the next patient that might benefit from a shorter length of stay and less blood loss. And you start thinking about that, and there are really good ideas here that could help your patients through difficult recovery. And I like to think of this as my last slide. You're either tunneling through the earth to go to your destination directly, or you're flying around it. And sometimes that flying around it indirectly, it might be a safer and easier way to go. So those are my thoughts on direct versus indirect. I think direct does have a role. I think indirect should have a bigger role. And I think as you're looking at your next patient, you should really weigh the risks and benefits of the approaches and consider leaving out that direct part. Can you do it safely and effectively? I believe you can. And I think it solves some of the problems we have with spine surgery, some of the complications and difficult management issues that we encounter and that our patients have to go through. So thank you. Have a great night.
We had a few comments from the LinkedIn forum online as well, and questions for the audience. Yeah, and one of them was really good. One was from Dr. Lusanda Bomella, and she's asked if how we address the facets at the back for those of us that do indirect. And I mean, I know that Alan, Basil, when they're doing open TLIF or posterolateral, you're debriding those facets, and you're basically coming across, and you're almost doing an osteotomy for every case, right? In some respects, if you go open from the back, because that's how you're getting your segmental lordosis. I mean, people that don't come all the way through there and get a significant piece of facet and even pars out are not probably, able to recreate the lordosis that I see on your x-rays without antibodies, right? So, you're doing that, but I suppose the question for the indirect people, and I can answer this a bit as well, is what do we do with the facets? Do we just put in perk screws and forget the facets? Or, do you do something to the facets when you're there on your MIS-WITSI approach? I mean, personally, I do it a bit case by case, but I generally now debride the facet and will take it off partially to try to get that a little bit extra lordosis, but also clamp those facets together as a good surface for rapid fusion.
Yeah, I'll use like a navigated drill and just percutaneously through my perk screw incision, just drill out the facet joints. More for fusion than anything else. I mean, I'm probably going to get fusion anteriorly anyway, but I'm there, and so I spend the time just to drill out the facet joints.
And Mike, so we looked at the Alan knows we looked at the ISSG data for fusion rates. The anterior fusion is extremely high, obviously, in MIS. It goes all the way to, what was it, Alan? 85%, I think, anteriorly. But posteriorly, there was 10 to 15% of fusion. Now, the examination was on x-rays, wasn't perfect. But the reliance on MIS is truly anteriorly. So I do know that, at least our MIS partners do burr out the facets and all that. But, I still think it's not truly... that's why I guess you guys do a case-by-case basis, because it's not predictable whether that's going to get fusion or not.
No, I agree. We're basically relying on the interbody fusion.
Yeah, which is extremely high rate of fusion anyway.
Yeah, may I just ask something? This is Alexander from Switzerland. Nice talks. I appreciate it. I learned so much. But relying on interbody fusion, every now and then there comes the next study comparing interbody versus posterolateral fusion. No difference. Comparing reduction of slip versus non-reduction of slip. No difference. Blood loss very relative to compare. 300 versus 500 can be significant, but clinical relevance zero. We have so many measurements. I think I see a danger that people who do a lot of laterals, not A-lifts, but laterals, pretty unlearn to fuse from posterior. The art, what you have to do from posterior is so completely different. So the preparation, detachment of muscles, everything you really hate if you're a strong believer in indirect decompression and fusion. But this is some kind of art. What Alan mentioned is so important for us. And I see in private practice here in Switzerland more and more a turnover to go to laterals in mono or bisegmental diseases. I just want to ask, do you really say that interbody fusion is the non plus ultra, or are we going for a theory of mind and we believe something which is not proven in the literature?
No, I don't do an interbody. I don't do an interbody fusion because I think it's better than a posterior lateral fusion as far as fusion rates. I do an interbody fusion because I think it's less morbid than an open posterior lateral fusion. And what the studies do show consistently is that an anterior lateral lumbar interbody fusion has a superior lordosis and disc height restoration than a posterior fusion or a TLIF.
If I could add something, that a really good surgeon who is very well experienced and practiced with posterior can likely get an excellent result with rapid recovery and low complication rates for most of these cases we're talking about. Similarly, a highly experienced surgeon with anterior approaches may be able to do it. And this is what you're referring to. If you don't do many posterior approaches, you may say, oh, that TLIF's going to be terrible. It'll be hard to get a fusion, hard to get a good decompression, high risk of dural tear. It's really, our specialty has grown so much that it's becoming very difficult to be a true expert in all approaches. And I pride myself on being able to achieve tremendous amounts through posterior approach, but I also fear the lost art. It's not easy to do to get an excellent result from an open posterior approach.
I agree with Alan. I think, and I agree with Alex that it's a bit. I'm concerned as well about how prevalent and how easy it is to access and learn lateral approach, and how easier it is to apply it in a community setting. Because the more you get higher in the lumbar spine, the more dangerous it is to restore the height and lordosis and build segments. We have seen a lot of spinal shapes and constructs that are with multiple lateral approaches up in the lumbar spine that eventually translate the thoracolumbar junction, overcorrect the spine, PJK. Obviously, we've seen it in posterior as well. We've seen it everywhere. As long as Alan mentioned, as long as you respect the principles that you're trying to go after, you decompress nicely, you restore foraminal height, but at the same time you do appropriate segmental alignment, lateral or anterior or posterior. I think it should be fine for the long term, at least for what we know today. As just 20 years ago, Harrington rod was the best thing ever. Today, lateral could be the best thing ever, but I think we should be careful. If we standardize the targets, like the alignment table we showed you on all these principles, it doesn't matter what you choose to do or how you learn to do it. I think we just have to kind of be consistent in what we aim for.
I agree with that sentiment, which is you can never compromise the ultimate goals of surgery. And so like my practice personally is 100% MIS. I haven't done an open posterior approach in 6 years. But that doesn't mean that 100% of the patients that come to me who need surgery get an MIS approach. So I'm in a practice with 20-something spine surgeons, some of whom do lots of great open spine surgery. So I see the value there. And so for those patients, somebody who needs a PSO, somebody who needs, you know, true open posterior column osteotomies, I'll send them to one of my partners to do that. And I think that's part of the key to being successful with minimally invasive or indirect decompression is knowing who you can help and who you can't help, and not just trying to blanket apply it across the board.
100%.
I think it's way easier to do a nice ALIF than to do a perfect TALIF procedure. So there's no question on that. It's just more time, more effort, and it's harder to do a good TALIF. This is one point. The second is a couple of things changed in the last 10 years. I believe back then we all was educated and learned that we have to have a bone fusion. And in between, for me, it seems like more and more colleagues are also believing in percutaneous fusion with a good interbody, which I still don't know if that's the right way. On the other side, if I remember how many big open surgeries with a lot of bone chips we revised, and how many % of these cases you did find bone fusion, it's confusing for me. I don't know the answer to that. I mean, in our experience, if you're putting in 18 or rather 22 millimeter wide cage, it's going to get fused.
I think the data, what we found in the ISSG data, open versus MIS, was that almost exactly the rate of posterior fusion is similar to the rate of anterior fusion at 2 years between open and MIS. So, right. So we, you know, I was like, all right, good. So, you know, if you go after the fusion, you'll get it. If you're thoughtful about it, you'll get it anterior or posterior. But if you don't, obviously, you're not going to get either of them. So, you know, at least the only data I know about is this 2 years data that we found last year.
So thank you. We're at our top of the hour now. So what I'm thinking is we might I'll put some answers to other questions up that were asked on LinkedIn. But I'd like to thank everyone for joining. I don't think we have a clear consensus. I suppose what I'd reflect on, though, is I think all of us train spine surgeons, right? You know, we've got fellows, we've got residents, we've got trainees, and we do have to train people on these decompressive techniques. Now, you know, this is important. So we've all got this baseline ability to do it. And then I think what you have to do after that is work out what you're comfortable with, you know, work out what works for you and move forward with it. And I think Alan actually made a really good point before, is it's really, really hard to be good at everything in spine surgery now. You know, and that's why, say, Peter, who I'm sure is more than capable, doesn't do huge multi-level open anymore, and I don't do endo. And I think that's what we're, you know, heading for, is a world where we do have to pick what we're good at, and that means we need good colleagues. You know, we need people to be able to talk to share cases with. And I'd really like to thank everyone for coming on and sharing their knowledge today. And David Yam's talk is going to be in this online as well, and we'll put it up online too, because, you know, we ganged up a bit. There were a few more indirect decompression than direct decompression talkers here, but I knew that the Brown team could hold their own. So thank you again to all the speakers and everyone asking questions, and really thank you for joining us. We'll see you next week. I don't know, Alexander and Ali, do we have a topic for next week yet, or we'll put it up on Twitter and LinkedIn? It'll go up online.
We'll see you on social media.
Yeah, thank you, everyone. See ya.
Good night. Good night, everybody. Great job.
Thanks. Good night. Bye.